Okay, so one key symptoms that is actually associated with acute abdomen is nausea and vomiting. You know, so when trying to clerk a patient that has nausea and vomiting, you pay attention to, okay, as you are vomiting, all right, as you are vomiting, are you having stomach pain? Then if the patient still complain about stomach pain first, you ask them, as you're having stomach pain, are you vomiting? Do you understand? So all of them actually complement each other. So when clerking a patient with nausea and vomiting, that's in the context of an acute abdomen, you are basically dealing with symptoms that may reflect anything from maybe benign gastroenteritis to maybe life-threatening, okay, things that need an emergency response. Do you understand? So in trying to approach this, you try to actually ask the patient around the presenting complaint. So either vomiting or stomach pain, as they say it. You ask them, how did it actually start? Was it sudden or gradual? All right. So how frequent do you have it? And what's the volume of vomit you actually put out? All right. So in our hospital, they usually give them a cup. So you use this cup to actually measure out, So for the content, is it bilious, feculent, blood stain, or undigested food you vomit out? Associated symptoms like, are you having abdominal pain? Are you having abdominal distension? Those ones basically you elicit them on physical examination. Is there constipation? Is there diarrhea? Is there fever? All right, you point all of that out. So key differential diagnosis is like things that could cause vomiting and stomach pain that you should be suspecting. Is small bowel obstruction. So small bowel obstructions, these are the things you should be looking out for. Gastric outlet obstruction, you should be looking out for this. Pancreatitis, you should be looking out for this. Epigastric pain radiating back to the radiating to the back. Appendicitis, you should be looking out for this. Peritonitis or perforated viscous, you should be looking out for this. Mesenteric ischemia, you should be looking out for this. Then diabetic ketoacidosis or uremia, you should be looking at all those metabolic issues. So history to elicit, for the pain, the abdominal pain, you use Socrates to know the site of the pain, onset of the pain, character of the pain, radiation, and all of that. Bowel habits, right? When last did they actually have stool, right? And what is the nature of their stool? Are they passing out watery stool? All right, constipation. They check out for fever and rigors. They check out for past episodes. Have they had similar things before? They check out for drug history. NSAIDs, opioids, chemotherapy, antibiotics. So you also check out for their medical history. Have they had diabetes mellitus before? Have they had renal failure before? Have they had previous history surgeries before? So the red flags, that's things that will basically make you know that you are dealing with an emergency. That's if they have had projectile or feculent vomiting, it's emergency. Hematemesis, blood in vomit, emergency. Signs of dehydration or shock. Peritonism on examination. If they have had altered mental status. So possible investigations that I could do here could be full blood counts, urea creatinine, liver function tests, amylase, lipase levels, C-reactive proteins. So imaging, X-rays, abdominal X-rays, CT abdomen. So urinalysis and pregnancy tests if you are dealing with a female of reproductive age.